Hi, everybody. Sorry, I was a little bit late. I'm topping up coffee after my quick Instagram live with Jose this evening. But also, I was just waiting for Gigi to finish her homework with my computer because I just need that for the questions. I'm just going to wait for a minute, make sure that we are streaming live because I can't see any sign of it yet. So I'm just going to check on my phone, see whether it's coming into the group, make sure it's not being funny, as it sometimes does. Hang on. Drink my coffee. Which one? Over there. I can't see anybody yet. If there is anybody and you're watching, then give me a little way. Oh, there we go. Numbers will start coming through. Sometimes I think there's a delay when I go live before it starts showing you all that I'm here. If you're here, welcome. StreamYard's a bit funny because it doesn't let me see who exactly is here. But either there, say hi, or give us a little wave or a thumbs up or whatever you would like to do, because it just starts notifying, I think, people who have allowed notifications that we are live. Oh, I've had a reminder. Q&A with me. I know, here I am. My husband's not massively impressed with me. As I said last time, I've set the Q&A reminders up, the events, so that we can remind you all that we're here, so you can come and ask questions, but it means it comes through to his phone, so he gets lots of pop-ups. So if you haven't joined us before, then feel free to ask questions as we go. Hi, Megan. Just pop them in the box. And I've also got a whole bundle that have already been asked. So I'm going to start working on those and see what things we get tonight. I always feel like I should really read them before I come on to make sure I know the answers, but I just go with the flow. And if I don't know the answers, then we'll look them up. So from Hazel. So my little boy was dairy intolerant when he was born premature at 35 weeks. If he has a lot of dairy, he gets diarrhea. He's on dairy-free milk and has been since he was little. He's now almost 14 months old, and I know I should have started the milk ladder, but lots going on. That's life, isn't it? I'm going to make a doctor's appointment about this. Is going to make a doctor's appointment what I should be doing, or can I just start? He has random bits of dairy, butter on bread, froth of coffee, but sometimes has much looser stool. He has had an ice cream, a bit by mistake, and diarrhea after that. Okay, so up to you, Hazel, as to whether you would want to talk it through further with your doctor. Depends on their level of experience as to whether you will get helpful advice, or you could probably just start and I can point you to some directions. So generally, you can see Danny in the background, my advice would be that where we're talking about these delayed allergies, and what you're describing is probably an allergy because intolerances are not so likely in the nipple ones. So it's called a non-IgE allergy, and they're the ones that give you symptoms 2 to 72 hours later of diarrhea, constipation, but when they go, it's soft, reflux, tummy pains, and possibly worsening of their eczema. And if they're really severe, it affects their growth. So for those ones, I'm happy for people to be starting alone. It's where you have the IgE allergies with hives, swelling, immediate vomiting, diarrhea, anaphylaxis that you need to be guided by your doctor. Or if someone maybe had started with these delayed non-IgE allergies, and actually when they've had accidental exposure, which is life, you then have noticed that they've had hives, then that again needs an assessment before we say start putting it in yourself at home. So you can start it yourself at home. Would I stop all of it? Well, it depends. So if like the bits of butter are tolerated without causing dairy, you can keep them in. But if you have felt that those bits of dairy have triggered diarrhea as well, then it's probably that he's not at that level yet. So we would use ladders, and there's multiple. The commonest one that's used is the IMAP ladder, which is the International Milk Allergy for Primary Care Guidelines. And but there are different ladders depending on the hospital. So you can have a Google milk ladders and see what suits you. They've got different numbers of steps in them, but the bottom one is usually starting with malted milk biscuits, starting with small amounts, slowly building it up, keeping that in the diet regularly, so 3 or 4 times a week. And it varies how quickly I move people up each step of the ladder, a little bit sometimes depending on age. So we know that if you started it really early, pre-12 months, you're probably going to have a slower pathway through. Whereas maybe if I've got a 3-year-old who life's got in the way and you haven't started it yet, I'd anticipate you might be able to move through quite quickly. So I might move through the rungs of the ladder every few weeks. I know Penny probably goes a bit slower, our dietitian. There's no definite right or wrong answer. We're trying to build some tolerance, but generally if you start that, keep it in 3 times a week, do that for a couple of weeks at least. If you're happy, you could try the next step. If little one starts reacting, you would come back to the step before, keep that in regularly, and probably then not retry for 3 to 6 months. So you definitely can crack on and start yourself if you're happy. And if you Google IMAP, there's also associated recipes. The other thing I really like is Allergy UK have got a cow's milk allergy guide, what's it called, a roadmap, which I was involved in, not the writing, but I checked all of it. So that's quite nice. That gives quite a lot of detail in there as well. So have a look at that. And someone was saying, failed milk ladder in the summer, not had a chance due to potty training and illness to try again. Yeah, and it is life, and people always beat themselves up that they haven't done all these things. But I think we're just too hard on ourselves as parents, because actually there's so much else going on. I've been rubbish recently. I still like to read to my children at bedtime. So even though my eldest is nearly 15, I like to read because I think it's a connecting time. But for the last few months, with everything else, work and how I've been feeling, most of the stories, bar my littlest, have gone out the window. But tonight I am planning to try to restart. But we shouldn't be tough on ourselves. There are reasons. But certainly if the last attempt was summer, then it's worth having another go again. And sometimes it's just that you need to go incredibly slowly. So if you keep having symptoms, maybe even just literally crumbs might work and might be the first time of reintroducing it and getting in, particularly if you've got an older child. So a younger one, if they're not tolerating it at 14 months, it's okay. There's still lots of time. But as we get on and you're sort of 2, 3, 4, 5, then I would be going for whatever you could and trying to get that in. And someone was saying, I'm nervous about doing the milk ladder with my 22-month-old. Oh, it's my 3-year-old who's anaphylactic. Okay, well, I mean, it's really difficult to take that away, because the reality is that when we've had any of our children have anaphylaxis or a really significant allergic reaction, and even not having your child having anaphylaxis, the first time Ethan was covered in hives and swollen lip, I was absolutely besides myself. It's really hard. I'm assuming your 22-month-old is not IgE allergic. And if not, then it's about trying to put it in where it's safe for your 3-year-old about the contamination. And I get that, because my eldest was the one with the milk allergy and not the others. But it is worth trying if you possibly can. And if it's that they're IgE allergic, but you've been told to start baked milk, just start small, literally a crumb, and just build your confidence and build their tolerance up. The one question above. So my 2.5-year-old still on omeprazole and awaiting a tonsillectomy, seems to have passed the baked egg challenge in hospital, still allergic non-IgE to milk and IgE to soya with eczema that's under control. What would you work on first, dropping omeprazole or trying the food ladders? Can have poor weight gain at times. Okay. I think it's a little bit about what do you want to do most. And I always say that with foods, like when we're looking at ladders and stuff, what would be the thing that would make the most difference to you? The reason we wouldn't want to do it all at once, for anybody who might be questioning that, is if we remove the omeprazole, and sometimes, especially if you've been on omeprazole, which, if you don't know, is given for reflux by some, I'm hesitant about its use. But it stops all the acid being produced in the stomach. If you've been on it for some time, you can get rebound reflux. So you might have to wean it really, really slowly. So given children will be on a liquid, let's just use the example that they're on 1 ml, you might go down to 0.9 mils for a few weeks and then 0.8, and do it really slowly so you don't get any rebound, particularly if you've ever tried stopping before. But of course, stopping the omeprazole, if you start getting reflux and you're doing a ladder, then you don't know which is which. So I would do whatever you feel suits, really. There really isn't a right or a wrong answer. I guess, no, we don't want them on omeprazole long term, because we know it can affect the gut microbiota and develop more of these bad bacteria when we want a good, healthy gut to be trying to put foods in, to trying to help allergies. And also it can affect their magnesium. and there are some long-term concerns about bone thinning. So we would want them to come off, but I don't know what I'd do first. If they were mine, what would I do? I guess there's an argument that hopefully omeprazole you could wean off within weeks, and then the ladders might take longer than that. So maybe start trying to reduce the dose and seeing how you go. But obviously having a really close eye on little one, because we want to be keeping an eye on that weight, particularly if there's someone that's struggling. So maybe I'd go with the omeprazole, reducing it, seeing at least if you can bring it down to the lowest dose that they need. I'll just log back in here a minute. Oh, come on, computer. Right, next one. Cara. Hi, Cara. I have a 12-month-old with a non-IgE cow's milk with... Oh, well, that's interesting because you put proven with skin testing. So I assume that the skin testing was negative and hence the proof, maybe. Been told to start the milk ladder. However, she has alternations between diarrhea and hard to pass stools daily and has a constant skin rash that doesn't seem to bother her. I very carefully introduced everything new to her to ensure we catch any allergies. Nothing new's entered, but we haven't been able to highlight any reaction to particular food. It's just random. Is it wise to start the milk ladder? Yet. She also has reactions to broccoli, strawberry, peach, quinoa and cashew, and a very bad issue with coconut, for which we're awaiting testing. Tricky. So when children get older, over 12 months, sometimes they start getting rashes, actually I'm younger, for reasons that are not allergy based, particularly if they are quite sensitive or they do have eczema or they are allergies. Then you can find that foods that naturally contain histamine, and some of them you've mentioned, strawberries, tomatoes, aubergines, can often make them very rashy, tends to occur very quickly, but for most, rather than resolve within an hour or two, I generally find they tend to last a bit longer, usually just make them look bright red, sometimes like they've been burnt, occasionally a couple of hives, and that generally isn't an allergic response. You also have foods which are quite high in something called salicylates, so things like the fruits, dried fruits, particularly those healthier like their yo-yos, raisins, and so children over time, when they have lots of salicylates in their diet, again, can be quite rashy with some soft stool. So it can be quite tricky because those things can go on for several years. They do tend to just get better with time. They don't bother the child. You don't have to stop the food. It tends to just be us as parents, particularly allergy parents, going, oh God, what is it now? So whether some of those things may be related to those types of rashes, particularly given broccoli, strawberry, peach are very, very unusual allergies to have. Not impossible, strawberry more so, but not super common, not in a 12-month-old. Cashew, obviously, it can be. So I'd be probably looking with a doctor about the issues with the switching between the diarrhea and the hard to pass stool, because sometimes it can be more sensible to be on a regular low dose of something like Movicol, which is a stool softener, to keep the bowels regular and soft rather than build-ups. And then looking at the ladders from them. But I agree, until you've got some sort of straight answer about bowels, particularly, because that's what we're going to be guided by when we're looking at reintroducing foods, I think it's a bit hard to do a ladder because you won't, and I've done this with a mummy where the babe was being weaned, and weaning can make people quite constipated, and we were trying milk, and really we just could not figure out, was it milk or was it just weaning? So we stopped the milk, trying to wait till the bowels settle again before we try it again. And it is fine to do that, just to wait until the right time. Otherwise, you all know what it's like with non-IgE allergies. You're second guessing yourself enough. So you just need to give it a bit of time. Yeah, trying tiny steps. We win like that. If you think about the concept of immunotherapy with food, where we are doing that for the IgE allergies, so there's no evidence around doing it particularly for non-IgE allergies. So the concept stands in that what you're trying to do is expose to the body to tiny amounts of the thing they're allergic to regularly. And with food, then we move up after that person eating that dose every day for 2 weeks, we move up a bit. So I think with non-IgE, if you've been someone whose child is now 5 and you're just not getting there, I know one of my lovely patients, in fact, I think, Mary, I saw you ask me a question about it, but if you're doing like literally a crumb for several weeks, that might be the starting point. And then the next weeks might be 2 crumbs. And it's a bit onerous with the cooking, but you can freeze stuff, but it might be what that body needs to start them behaving and ignoring what should be harmless. So just slow and steady. Excuse me. So Bethany has said, I hope you're doing okay. I am, thank you. I posted in the group and a few other people replied, but I wondered what your experience was and if I should be thinking outside of Albie's milk allergies. He's currently tolerating half a muffin with step 2, but notice he's definitely got an increase in earwax. And she showed me some pictures. I mean, it's a funny old thing. Milk particularly, people describe all sorts of upper symptoms, so congestion, but in the absence of them having IgE or non-IgE allergies. And I know that because the tests are negative and they've got no gut symptoms. And often this is adults. So I've never heard particularly, and it certainly is not a listed symptom, the increase in wax per se would be associated with milk. I would think it's probably coincidental, I guess, given earwax is there as a protective measure to be trapping bugs and debris and then pushing it out from the ear. I probably wouldn't let that bother you and stop it. I think the other thing I would say is make sure somebody's actually looked in his ear, just to make sure that, I'm not sure how old he is, I've got a feeling he's little, but forgive me for not remembering. But children put all sorts of things in their ears and their noses. And having done years of ENT, the number of mortified parents, including myself, where their kids have shoved stuff up their nose or their ears, or quite often the parents won't know and they'll start having increased discharge either from the ear or the nose. And then they bring them to me as an ENT doctor, then have a look and we see a foreign body. So can't remember how old Albie is, sorry, but if he's old enough, make sure he doesn't shove something in his ear. But otherwise, if it's all clear, I would just leave it alone, but carry on your milk. I don't think it should stop you. Yeah, Megan. I got confused, Megan, earlier, because I think you were also putting on the group question thing that I set up on Gareth's phone, and then I was confused about the milk situation. But you've put, where can you turn when your entire life is upside down because of an allergy and no one has any answers? I suppose that's anything in life, isn't it? That sometimes we don't have answers to things, whether it's allergy, other health conditions, other life things. And there's something that has to be said of a understanding that there is only so much that we can manage and control. And when we can't do any more than that, we can't beat ourselves up. We don't know the answers. I know your particular situation with your daughter with extremely difficult milk allergies. I'm hoping that the milk OIT is going to be the thing that changes her life and yours. And it is difficult. I don't know. It's hard. We're here to support you. We just sometimes we can't make situations any better, I think, is the honest answer. Have you managed to start the milk? I know that it was going to be done at home. I'm wondering how you are with that process. Another question that's coming on the side, how can you tell the difference between allergy and dermatitis or eczema? So, dermatitis is like you posted it a few months back. Maybe you did. Oh yeah, you did 14 weeks. Am I repeating the question? Oh God, I'm probably answering the same questions. Thanks for pointing that out. Hopefully things are a bit more settled than when you answered that. I reckon I've answered all the same questions, but I think it's the same themes that come up. So hopefully that's all right, Megan. So dermatitis just generally means inflammation of the skin. When we are, then there's different forms of eczema. So there's like atopic eczema, which generally we would be saying that's likely if this is somebody who has had eczema from an early onset and particularly then lifelong. So either coming and going but particularly when you've had it from very early in life, it's usually atopic, i.e. we know that means it's usually genetic, that their skin barrier is not normal, and that these young children have increased risks of food allergies forming. They don't always have food allergies, and they may also have increased risk of environmental allergies and asthma. In terms of like differentiating the type of rash, so eczema is classically itchy. In older people, it would tend to occur in the creases of the arms, the backs of the knees, whereas in infants it tends to start on their face and then on their trunk, and as they get older it goes into those patches. Allergic rashes, obviously they might be hives, which looks different, so they tend to be pale and raised and extremely itchy, but they come and go quite quickly. Even if you have other hives appear next to it, that individual hive resolves and goes away without leaving any marking. And that might come quickly after exposure to the thing you're allergic to and then resolve. Or some people just get hives that just keep appearing, that's what we call spontaneous, or maybe triggered by a virus. Some children with the non-IgE allergies don't necessarily get eczema because they haven't got changes day to day, but they just get a bit rashy when they have that food, and it does come and go quite quickly. And then thinking about eczema, that it's usually, again, in an allergic individual, but where there might be patterns. So thinking, is this a contact dermatitis? So in terms of, is it due to a chemical trigger? Then we're usually looking like for set patterns. So I had a lady asking me about, was it related to her acrylic nails? That was quite a big thing in the newspaper a while ago. So then those people would tend to have changes around their nails. So if you remove the acrylic nails, their nail beds would be raised. And then quite often they have eczema on their face because of where they touch. People with eczema maybe only on their face, we might think about, is that some sort of product you're using? So the dermatologist would look at patch testing, where they put the chemicals across your back, leave it several days, and they're looking to see, does it trigger delayed rashes? They're a bit limited in how frequently they do that. And I'm told in our area in Dorset, they don't do it privately. They actually still refer them into the NHS, even the private dermatologists. But really, they're looking for patterns. So when you've got widespread eczema, it's probably not likely to be due to an external trigger. It's coming from within. So it's when you've got it around like a wrist strap, we might think it's nickel, or as I say, sometimes if it's just the face, they might do patch testing. So how can you tell? Well, I guess that really is the role of the specialist, to be trying to have a look and unpick that history for you to figure it out. What you said, Megan, no IT due to random facial reactions at school. The hospital don't want us to homeschool and no IT at the same time, as they say it is too overwhelming. Everyone who knows us disagrees. School life is massively overwhelming, yeah. But OIT won't give you an official reason to homeschool, so you can't win. That's really frustrating, isn't it? I mean, obviously the change to her life from working at school to coming at home is quite a big thing. But many young people, not all, because my stepson homeschooled for a while, he hated it. And it was just circumstance why we needed to. But many people find it less stressful because there aren't the external triggers, and for your daughter particularly, wouldn't then be having the reactions at school. So I don't know whether you could write a case, spend some time together writing an argument and actually write it down to present to them, rather than having to try and think on the spot about an articulate reason. ChatGPT is good. You can use ChatGPT. So you could put in some points and ask them to help you formulate a nice rounded response and ask them to discuss it further with you. That's what I would do. My little girl passed step 3 just over a week ago. Well done. And we've continued including milk once a day, alternating between steps 1 to 3. She's chesty today, full of congestion, has a temperature. I don't think it's allergy. She's unwell. Should I be more cautious with the maintenance dose or continue as normal? I believe illness can impact on the extent of IgE reactions, ... because this is where StreamYard cuts me off. I probably can guess. I would say, so it's usually with children with the IgE allergies that when we are trying food, we are very cautious if they are unwell, particularly with a fever or a cough, because if they are still going to react, then potentially they'd have a more serious reaction if they're unwell. Same as for anybody with an IgE allergy. If you're unwell on the day you are exposed to the food you're allergic to, that's when we see more serious reactions occurring. But with having already passed it, regardless of whether it was IgE or non-IgE, but we've been happy and we're passing it, I would just keep it in as maintenance, but just don't step up any further at this point. Okay, so someone's written, my throat's swelling up and neck is feeling stiff. What should I do? That was a tricky one without any context to that, because I don't quite know in what circumstance you're talking about, because throat swelling can be quite a subjective thing, in that you can feel like you're swollen or that there's something there. It's quite hard to ever actually fully see that it's swollen. which is why we often look for more objective signs. So voice change might imply there's some swelling around the vocal box, or occasionally you see your uvula, which is the dangly bit, really swollen, but I've seen that lots in non-allergic causes too. So I'd need to know a lot more about what that means to be able to give you some context around what to do. Can't find a place to put the question here, it's fine. What's the difference between cetirizine hydrochloride and cetirizine dihydrochloride? Daughter on the first brand of Cipro, which is 70% sorbitol solution, so it's sweet. So she likes it, but looking to change to Benadryl, which is dihydrochloride, and not sure if she takes it as reviewed, lots of flavors, etc. It's the cetirizine which is the active ingredient within it. I've never even noticed, to be honest, between the two. Let me just have a look for you, but I can't see that there's any particular difference. So I think you can try both because it's the cetirizine component, and you'll notice that because it will have the same dosing on it. And yeah, they all have different flavors. Some children react to the sorbitol, so they can't have them within some medications. I can't even see a difference. I'll look it up a bit more for you later, but I think they're exactly the same. They're often just different trade names. Yeah, they look exactly the same to me, so I would carry on. And again, it's cut the other half of your conversation off. I'm sorry. Let me just see if I can see it. Why am I screaming? I see myself. And then I'm going to find the up-to-date questions, because I reckon I've just answered loads. Sorry, bear with me. It's never showing me. Oh, I hate screen ad. I like it and I hate it. Right, let's go back to trying to find my questions, and I'll go to the most. See if I can. Okay, I'll just start right at the bottom and work back up. So Michelle has said, my 7-year-old's diagnosed with a peanut and tree nut allergy last year, hasn't got eczema or asthma, and never had anaphylaxis, so not prescribed an EpiPen because been told low risk. Should he have one? I'm terrified. It's a question we get all the time, and the answer is maybe. So the guidelines from the British Society of Allergy, which many people would use, particularly as GPs might stick more rigidly to it, and then they'd be guided by an allergy service, are if you've had anaphylaxis to food, bee and wasp stings, spontaneous, then definitely should have it. If you've had asthma and you've got those IgE-mediated allergies, we ask them to have it because they are more at risk of anaphylaxis because asthma is a cofactor. So I always talk about this perfect storm. So if you're exposed to what you're allergic to, you're more likely to have severe reactions when other things are there on the day, like illness, like asthma, particularly if it's bad, like exercise, taking ibuprofen, weirdly, stress, alcohol, what else? Stress, alcohol, being around your period, those things are cofactors. Then there is a box that says consider it for, and the consideration says if you have a nut allergy, particularly a peanut allergy, consider it, or if they've reacted to trace amounts. And I think that's open to interpretation of what do you mean by trace amounts. For me, it means I put food in my mouth, spat it out, and I had a reaction. Maybe that you knew that they had tried, I don't know, been kissed and reacted, a contact reaction perhaps, although you do get contact hives in children, but maybe if you've had a contact reaction but it's triggered systemic symptoms, so vomiting or any tummy pain or more than just hives, or just tiny amounts. For me, it's a consideration. And the reason peanut is in there as a considerate is because there is some evidence to show that if you gave someone with a peanut allergy enough of it, it would trigger anaphylaxis in up to 75%, which isn't the same for all the other foods. I also personally consider it, and it also says consider if you are living remotely or traveling remotely. I consider it for anybody who asks me, because you cannot guarantee that anybody with an IgE-mediated allergy would not have anaphylaxis. And I do always try to reassure that deaths are very, very, very rare. I always say the number, we see around 20 to 30 a year in the UK. So what's that, around 2 a month and that's from all causes. So bee and wasting, food, spontaneous, and drugs. So, and in all ages. So it is very, very rare if you think, considering how many people have allergies, but you could never actually say who are going to be the people where they have these severe reactions. And therefore, it's always a conversation in my mind. So I think if you feel like you would really want one and your reasonings for it, I think you take those guidelines and say, it says consider it for a nut allergy. And for me, I feel like I would want one because you couldn't guarantee they can't have anaphylaxis. And I would be surprised if they said no. And I have had people see me privately because they want a prescription. I'm happy to do that if people are willing to accept that you might have to pay for the private prescription. So it costs about £35 to £40 per EpiPen or Jex, and we would prescribe 2. Usually at school we prescribe 4, 2 for school, 2 for home. I do try and write back to GPs or allergists to say, would you consider it? Because blah, 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 blah. I just can't guarantee they would, and therefore that you would be able to get it on the NHS. It's not me that charges the prescription cost, it's the pharmacy. But I do have people come for that reason. Cara, so it's complicated. Currently under a consultant investigating a respiratory condition for a year, going down the genetic route now for cystic fibrosis or something called primary ciliary dyskinesia. However, is it possible it's an allergy? What's interesting is when we were in Dubai, the symptoms completely disappeared, but when in the UK, they come back within days. No allergy to the dog, as we have dogs around us in Dubai. I think, again, it's hard to know what, it depends on the symptoms that are being described. I'd be surprised if a respiratory consultant has given no thought to it possibly being allergy, but the sorts of symptoms I see associated with environmental allergies, usually rather than food, would be, so if they've got no symptoms, so sneezing, snotty, congested, itchy eyes, they might have frequent upper respiratory infections, so blue ear, coughs, colds. It can trigger cough because often they've got quite a lot of inflammation and it drips. So children who are young, where someone's querying is this asthma, and by young I mean like 1 to 4. Oh, noise upstairs. Quite often actually there's something like a house dust mite allergy going on. So it could of course be in Dubai that it's a lot hotter, whether that climate would be different, although that shouldn't make a difference really to the conditions that you've described. So by all means, you could ask either your GP or the doctors whether they would consider doing some blood tests for an environmental panel, and your GP can do that, so they can send it off. I think it's called environmental panel, and it checks grass, pollen, tree pollen, mold, cat, dog, house dust mite, or obviously privately we can do that. We can do that on home tests, we can do skin prick tests. So possibly, but I'd need to know a little bit more about the respiratory uses. It wouldn't, if you have environmental allergies, have any changes on your x-ray or anything like that. So it depends on little one, who's very cute, specific circumstances. Rachel. Thank you for answering questions. No worries, we finally cracked having half a boiled egg. She also can have half a pancake. Is the next step scrambled egg? And when do we move to this? And how long do you suggest cooking the egg for when scrambling? This is our silver lining this week. It's a good one because nursery unfortunately had more contact reactions, which was probably milk. You will get there. I definitely find, I know there are exceptions, Megan, your daughter's one, but many children who have a lot of contact reactions when they're little, and my son was like that. As time goes on, even if their allergy doesn't go away, often they seem to be less reactive to touch and surfaces and things. Not everybody, but generally. So on the milk ladder, depending on what egg ladder, depending on what you use, I have baked egg, which would be things like cake, dry pasta. I think it's got things like Milky Bars in there. The middle bit would be what we call loosely cooked egg, which would be boiled egg, scrambled egg, pancakes, Yorkshire puddings, and then the top is raw egg, so things like licking the cake mix bowl. So if she's managing half a boiled egg and pancake, there's a good chance she would manage scrambled egg. So you could go on and try it. You always want to make sure, because you're on the middle bit, that the egg is completely cooked through, so it's not raw. You will find that the looser it gets, so like with a boiled egg, if it's dippy, that potentially that's not going to be tolerated. So I would want 3 months to 6 months at least of tolerating the middle section of well-cooked scrambled eggs and boiled eggs before you then move on to making the scrambled egg and the boiled egg less well cooked. Megan, this is a more up-to-date question. Is omalizumab something that's only ever used for uncontrolled asthma? Could it be used for uncontrolled allergies that normal antihistamines don't touch? Thank you. No, it's not only used for asthma. So traditionally, that's where, quite some years ago now, most of my patients were on it for asthma. Then I've most seen it used actually for people who have spontaneous anaphylaxis, but that's because of the role that I do. So particularly teenagers having multiple episodes of spontaneous anaphylaxis, then it can be used for that. And in research, they are looking at using things like omalizumab alongside OIT, so oral immunotherapy, to see whether that helps induce tolerance and get people through the OIT. Would you have it just because of uncontrolled food allergies? I've never seen it used in that setting, so I think it would, whether it would work, but I've not seen anybody do it. But they do it alongside the OIT in research. So yeah, watch this space. There's lots going on at the moment. Should I ask for bloods for environmental allergies when he's had skin prick tests confirming some of these, i.e. dog, grass, dust, light? You don't have to. So if the skin prick tests are positive, the blood test won't add anything. If the skin prick tests were all negative, it's worth asking for bloods if there's a strong suspicion to check. You do sometimes find one's positive and not the other, and same for food allergies. And so, for instance, I had a chap on the weekend. We did skin prick tests. He was positive to Alternaria mold and tree pollen on the skin prick tests, and on the blood test that we also did for various other reasons, he only had the Alternaria mold. I'm similar in that I think I am skin prick positive to house dust mite and grass pollen, and my blood test was only positive to grass pollen. I personally, I don't know whether this is definitely true, but I always get a sense with this environmental allergies that the skin prick test seem for me to be more accurate. And that's definitely also true when it comes to bee and wasp sting allergies, that you can have a lot of false positives on a blood test, but actually we do skin prick tests and that's much more accurate for bee and wasp sting. The foods are very similar when you look both across. So depends on the circumstance. If the skin prick tests were positive, you don't need to do the bloods. If they weren't, but you're suspicious, then do both. Yeah, don't think her reactions to food allergies. Definitely something airborne. I'm convinced it's the ventilation system, but Sunday night anxiety. Yeah, I think it's really. If people don't know Megan's situation, sorry, Megan, keep saying, but because we do keep trying to help you unpick it. With your daughter's got quite significant milk allergy and has anaphylaxis, and you've been wondering whether she's having more reactions at school because it's coming through the ventilation system, particularly because it doesn't happen at home. And I think that's really tricky because I've never heard of that before. And although we have seen that milk is airborne, I don't know, does it happen in all other aspects? Or is it that she is having an element of spontaneous anaphylaxis? And that would be more common in a school situation than a home situation where there are added stressors. And if she is having spontaneous anaphylaxis, she is going to struggle with milk OIT because you're going to be really hard to age. She's going to be more anxious, which could trigger more of these reactions. But B, because you're going to have a hard time figuring out, is it the OIT or is it spontaneous or what's going on? And in those instances, they would potentially use omalizumab. They would also usually normally start with regular dose of antihistamines, up dosing to 4 times the normal dose. So cetirizine 40 milligrams a day for an older person. Safe, off license, risks of side effects like drowsiness, but is safe to do. Then sometimes we add in montelukast, and then we normally get to the omalizumab. So obviously I'm not her doctor, so I can't necessarily suggest those if you haven't been doing it. But there is a question of trying to unpick a lot more of, is it definitely milk and the airborne stuff, or is there a spontaneous element? Would she benefit from this? I can't remember what, I think you're up. Can't remember your centre, whether you're London. Just facial reactions. Literally itchy nose and eyes. Okay, so not anaphylaxis. So they probably wouldn't do it for that reason, but we would updose the antihistamines. We would sometimes look at something like famotidine, which is traditionally used for acid reflux, but it's another histamine blocker. And then London. And then we also sometimes would add in the montelukast if you haven't. Tranexamic acid can also work really well, as the coffee man, for swelling of the face. whether you ever want to join the membership and have a one-to-one, I can't guarantee that I would definitely be able to help you, but I could try and explore with you a little bit more. I also can't promise that London would even vaguely listen to me, but yeah, sometimes knowing what you're going in. Yeah, Montelucas. The sun is amazing. My son, he is meant to be on it. He was on it. He's refusing to take his asthma medicines, but there you go. That's another story. But some children and young people get night terrors, behavioural disturbance, or sometimes even mental health difficulties. Oh, well, I do have wings. They're just tucked under my jumper. I'm going up here for the question. Is this a stupid question? Sorry if it's a stupid question. There's no stupid question. It just means we don't know the answers. Is there a wheat and a gluten ladder? And if so, what does it look like? Sort of. There are actually wheat and gluten ladders, but they can be quite complicated. So what Penny, our dietitian, often says is to, I think she starts people on, I want to say a 16th of a piece of bread. I'm pretty sure that's how she does it, and make sure that's being tolerated regularly. Then she goes to an eighth, then a quarter, then a half. Hang on. She goes a 16th, eighth, half, quarter, half, quarter. Oh, it's been a long day. So just slowly increasing it. One of my other dietitians does it by just getting children to start with one pasta shell and slowly increasing the amounts of pasta shells, because otherwise I think it can be quite complicated with the wheat ladders. So those are the ways they tend to do it, to just start in tiny amounts basically and increase it slowly over time. So rather than you moving from a biscuit in step one of the milk ladder to then a muffin, you're moving from a tiny bit of toast, bread, keeping that for several weeks before you move up to a slightly bigger amount. And that's often the easier way. And that's definitely not a stupid question. Why would we know these answers? Honestly, if you heard the stupid things I did when I was a doctor to my son with allergies, so there you go. Hello, Sylvia. We have cut out, I saw your question in two places, Sylvia. We'll cut out milk in all food. Baby is now 20 months old, diagnosed with milk allergy at 5 months, but can't control his eczema. What would you suggest we do next? Okay, so eczema is not caused by food allergy. Lots of big studies proving and showing that, but we know that it can be triggered by allergic reactions. So for instance, if someone has an IgE mediated allergy, like Fletch, one of my lovely little boys who I look after, I know Mummy Carla often comments, if he has something he's allergic to, he'll have his immediate onset of hives. That will go away quite quickly, and it definitely always then triggers his eczema for several days. For other children with the non-IgE allergies, you would be looking for gut symptoms, as we talked about, reflux, bowel changes, and whilst the food that they're allergic to remains in their diet, the eczema is really hard to control. Even when you pull it out, it often looks like the eczema sometimes even is gone, but it invariably comes back, and then people start going, what else shall I exclude? And the answer is nothing. The eczema is there, particularly from a little age, because of the genetic change, which means the skin barrier is not normal, can't waterproof itself, dries out, and gets recurrent inflammation and itching. What is my dog doing? What are you doing? So I'm always mindful of people removing foods from diets if there are no clear IgE or non-IgE signs. If you're going to try it for 2 to 4 weeks, but if there's not been improvement, put it back. I literally this weekend was speaking to a lovely lady, old adult, removed lots of foods for years, really thought it was flaring her eczema. I'm not certain from bits she'd said in the history, and then accidentally given soya and had anaphylaxis, because when you remove foods for long periods of time from people's diet with eczema, there is a risk that they will lose any tolerance and become anaphylactic allergic. So what should you do next? The next is the eczema really needs looking at to figure out what on earth treatment do they need to try and bring it under control. We can't cure it. It may just go away in time, even when it's genetic, but it definitely needs better control. And we've this week, I think we've had, I don't know, about 5 or 6 people joining just because of trying to help manage the eczema. So you're welcome to join membership. We have a one-to-one. I can go through the eczema stuff with you, or we do have an eczema course that lovely Adette has written with me, which talks about allergies and all about understanding eczema and all the management, so that you know what to take to your GP. So if you look on drhelenallergy.co.uk and learning, there's loads of modules you can buy. One on milk ladders, eczema, hay fever, psychological ones. We've developed loads for you to try and help with all the different angles of allergies and eczema that you can't manage. Fundamentally, it's about really good moisturization, 4 to 6 times a day when it's bad. Ointments are preferable. If you're worried about reacting to skin, 50/50 is a good one because it's got none of the additives and it's just the paraffin, which tends to be better controlled. And then it's about what active treatment do we need to bring it back under control? Is it that we need to be using steroid creams? There is good evidence about the safety profile of the mild and the moderate ones. People often don't use enough for long enough, or they step off too quickly and it bounces back. Sometimes these little babes are on it for months and months, and the evidence is that as long as we always review it, the topical steroid withdrawal is not very common at all. It is really rare. I'm not even convinced I've ever seen it. Really, genuinely don't think I have. Maybe I'm just still not convinced, actually. Maybe one I was going to say, but I'm not convinced. The problem with topical steroid withdrawal, well, untreated eczema where it looks dry and flaky can look very similar to topical steroid withdrawal but you would expect it not to happen until you've had well over a year of treatment. So in this younger group, it's about using the steroids in the right length of time, reviewing the history to see if there are any other allergies that we've missed, and then thinking about actually if with steroids are not right, what are the other treatments that we need? And there isn't a magic cure. I keep saying that so often because it really drives me nuts when I see eczema families or eczema adults targeted as, I can cure your eczema, buy this wonder cream that costs £100 a jar. And it's not true. Otherwise, we would give it you. But your treatments are basically steroids, protopics, light therapy, immunosuppressants. There's nothing else. I wish there was. They do keep looking. How similar is the exposure to an allergen via a skin prick compared to actually eating the allergen? Is the amount very, very small. Very, very, very small. So it depends on like which type of skin prick testing you're doing. Most of the skin pricks we would do are using a solution that's basically got protein within it of the allergen. So grass pollen with a bit of the grass pollen protein or peanut. But some of those solutions are not brilliant. So particularly sesame can be a bit variable on a solution. Wheat can be a bit variable as well. So sometimes it's better to use like tahini, which is sesame, and we prick the tahini, prick the skin, or wheat. Was a good tip from an adult allergist. I haven't started it yet, but they use semolina and then prick the skin. And occasionally, if it's something a bit random or depending on the centre, they may not have a whole bundle of skin pricks. I invest in them, but they do cost £20 to £30 plus VAT plus delivery, and they've got a shelf life, which is why it's hard to always have them in. So they ask you to bring them to clinic. I do know somebody who had anaphylaxis to when we pricked the nut butter and pricked the skin. That anaphylaxis looked like that child basically started, I think they complained of a bit of tummy pain and started coughing. So we didn't leave it and we treated it. And actually everyone was calm, and the parents, we used it as a learning tool for using their adrenaline autoinjector. But when I spoke to my colleague about it, who's a consultant there, he said he's never seen that ever happen before. So it is extraordinarily rare. I have seen much more commonly children or adults that maybe get one hive and they might get another couple, sometimes even here, sometimes a bit flushed. That is the most I've seen, and I do loads of them all the time. So I can't say it never happens, but it's extraordinarily unusual. And that's why you're in a setting with somebody who's ready to treat anaphylaxis if that happens, but it's extraordinarily unusual. So much, 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 much safer, or we wouldn't do it. And there's never been a reported death that I'm aware of from a skin prick test. Otherwise, we would all be much more antsy about it. It really is generally a very, very, very safe thing to do. I hope that helps. Currently weaning my little one, who has milk allergy, had all the allergens other than milk and soy, and seems to be okay with just increased spit up and the odd mucus nappy. Should I be worried about it or just carry on? Carry on. It's also normal too. And I think it's just that when we are down a path of allergy, we can never ever consider anything else, and that's like totally normal. But actually, mucus is normal. We have goblet cells in our intestine that are designed to produce designed to produce mucus, to lubricate. And so sometimes we all have a little bit. You may not see it. That's why we get a little bit stringy. It will be more if you're poorly, if you're teething, sometimes just with changes. But if mucus is the only focus, I never worry about allergy from that point. And a bit of spit up, that's normal too for a babe. So if you've seen nothing else, it sounds like things are going great. There's whippers in the background. Okay, I definitely did. Hi, Lucy. If my allergy is bad stomach cramping, diarrhea, vomiting after shellfish, and I go to a restaurant and they say there's no shellfish in the dish, but the ingredients are cooked in the kitchen, should I eat there? I find restaurants are vague, aren't they just? So I guess my question would be, is it 100% certain that you have an allergy? So shellfish tend to be very high in histamine. And if they are not quite fresh, then histamine levels can be very high, and cooking it doesn't affect the histamine. So you can't tell that it's not ripe. It still tastes lovely, but actually it's really high in histamine. And that tends to then give people really bad vomiting and diarrhea, and often flushing. And it's called rhomboid poisoning, and is mimics and mistaken for a food allergy. So the first thing I'd want to do is know that you definitely have had IgE blood tests and skin tests to show that you are definitely allergic. Or is this just that the episodes you've had have been related to histamine, or perhaps you have a relative histamine intolerance where that's just a no-go for you. And in which case, it wouldn't matter about the potential mild cross-contamination. Let's assume you are IgE allergic, where it gives you vomiting and diarrhea. First of all, what I say is, if that's true and you had a positive allergy test, just because you've never had anaphylaxis does not mean it cannot occur. So I'm forever correcting people when they say theirs or their child's allergies, which are IgE allergies, are only mild. Drives me nuts when they're also told that by doctors, because there's no such thing. Yes, your reactions have only ever been mild, and hopefully they only ever would be. But as we talked about earlier on, it's that perfect storm. Have an illness that your body's fighting off. You've run to the restaurant before you've eaten, you're at your period, something else happens, then that next time could potentially be anaphylaxis. Maybe not, but there's always the potential, which is why I don't understand how anyone can ever falsely say to people, you definitely don't need adrenaline auto-injectors. That's another argument. So in terms of the restaurant, I think it's impossible to not eat out just because they cook what you're allergic to in the kitchen. What you want to know is that they are washing their chopping boards, they are not using the same scoop, that you feel like there's good procedures in the kitchen to minimize contamination. So we all accept that even in our own kitchens, very often we cook with the things that other people are allergic to. Not everybody, some exclude it, but many of us do. So therefore, every kitchen is a may contain. That statement drives me nuts. I think it's utterly unhelpful for families and allergy sufferers. You just want to know that you are having good, sensible procedures in place, that in this particular cooking area, you have wiped the surfaces, you have cleaned the pans properly, and you are not putting spoons across. And in that case, then it's safe to eat there. And I think this is the one thing that restaurants do not understand. And I was frustrated, I say this with Pret, because they, when we talked at the Anaphylaxis Business Symposium, came up to talk about their allergy processes, which after what happened with Natasha are now phenomenal. I was so impressed by the processes that they have in place with head office sending through things. They have to have multiple checks at every level now when they make up their sandwiches, etc., on site. So they have to bring all of the food products that they want according to the card for the sandwich they're making to their area. A manager then checks it. They make up that food. They've got separate lids and containers. They put it all back. They label it all. As far as I could say, there is no risk of cross-contamination with the procedures that they have in place. But they've said, because we have the other allergens in the kitchens, we put may contain. And I just think that completely loses the point of may contain, which is meant to be there as a precautionary labelling, where due to the storage processes, the manufacturing, there's a possible risk that that food could have got in. So for instance, on a chocolate bar, they make chocolate bars with nuts, they wash the machine through with chocolate, you can't use water. And because you wash it through with chocolate, it means it's very hard to really be sure of thoroughness. And therefore, sometimes nuts will be caught and will contaminate that other that chocolate bar. And therefore, Chocolate bars with food labelling that say may contain or traces of or not suitable should be heeded because they actually have a real risk. If you in your machine have washed clearly and are not using that food, don't put a may contain. Rant over. I keep meaning to contact them to discuss it further because I was so impressed by their processes and they undid it at the end. So having listened, if I had allergies now, food allergies, or if my son still did, I would 100% eat in their restaurant and just avoid the food that said, obviously if it says in bold what you're allergic to, fine, but otherwise, for me, I would eat them because I thought they were brilliant. I just was frustrated with them. I think there are more here. I'm going to click that. So here's Mary. How consistent do I need to be starting the milk ladder, starting with a crumb? Is once a week okay, or would it need to be more frequent to be more effective? Once a week doing okay, but if 2 consecutive days, eczema flares a bit and he gets a headache. And this young man has had quite tricky symptoms. So I would really be aiming for 3 times a week if possible. But if in the beginning, now, I really would be trying to, because even if we're thinking about trying to use it in a concept of immunotherapy where we're trying to build that tolerance, once a week is just not too much. So if you can do it every other day, do that. That's what I'd be trying for. If exclusively breastfed baby has suspected non-IgE milk, soya and egg, all gut symptoms and congestion, all confirmed on reintroduction, challenge, well done. At what stage age should the ladders be tested? And should these be done via baby or via mum's breastfeeding diet? We normally advise that once you've confirmed it with the re-challenge to leave it out for 6 months. On the whole, that takes babies to something between 10 to 12 months of age, and that's about the right sort of starting time. And then when it comes to it, if they're all these non-IgEs, then choose which one you want to start first, which ones would make the most difference to your life. Most people say soya because it's everywhere. And I would normally recommend you do 1 ladder and get as far as you can before you then go on and start the other ladder. So if you get to stage 3, but you're stuck there, then start the next stage. But if you do them all, it's really hard to figure out what's causing what. So choose the one, but 6 months roughly. If when you come to reintroducing foods that you've had excluded with non-IgE allergies, if your child has eczema and if they still have significant eczema, then when you're doing the ladders, I would be personally doing very, very tiny amounts just to be sure you haven't switched to an IgE mediated allergy and developed those symptoms with hives and swelling, etc. And that was what happened when my own little man had non-IgE symptoms breastfeeding. When I then tried it, because his dad wasn't convinced, he had a full-out IgE reaction. So just try small. And in terms of to baby or to mum, 100% to baby, so much easier to figure out what's going on when we can directly give the child to the food to the child to see actually what's going on. What's the main difference between milk ladder and milk OIT? Does one give better results? They're both kind of a similar concept in that we are trying to see if we can induce tolerance. OIT is, so oral immunotherapy, is done for IgE-mediated allergies only, whereas many of the non-IgE allergies are really when we're talking about the ladders. We do use ladders for IgE allergies under the direction of an allergist, usually for egg and milk and soya. When we are doing immunotherapy to food, we know that there's always risk of anaphylaxis because we're giving that person what they're allergic to. And we start with the most minuscule amounts that are smaller than you would see on a ladder. So for instance, with peanut immunotherapy, there's not a ladder, but 1 peanut is 300 milligrams. I start them with a dose of 3 milligrams, so tiny. For the milk OIT, which is not routinely done, it's not even done particularly privately as far as I'm aware, definitely not with Adam's team in London at the moment, because of safety concerns, because they're just not sure, but there are some centres doing it. They will use different protocols, often with boiled milk where they think it might be slightly less reactive, but you're starting on mils. So you tend to be starting on different forms and tiny amounts. The first doses usually are given supervised, and then that person goes away and eats that dose for 2 weeks. They come back and they give an increasing amount. with some people doing something slightly different. But from me, as far as I'm concerned with immunotherapy to food, it's done supervised and they go home. The other thing with the OIT is that they have very strict rules around it. So we tell that person they can't exercise for several hours, they can't have a hot bath or shower, because those things can tip that person into having a more severe reaction. And this is because what we're trying to do is sneak in tiny bits of that food into that person's diet under the radar of the immune system to try and slowly build tolerance. And when we finish OIT, we get them onto an amount. So for peanuts, we get them onto 2 peanut M&Ms or 1.5 peanuts. And we know that from studies that when they had a food challenge, they were likely to tolerate more like 10, but not indefinite amounts. Whereas when you're actually doing the ladder, what we're doing the ladder to see is, has this person outgrown their allergy and can they now tolerate this amount? Because that's really what should happen. So it's not really the same concept, because for immunotherapy, we are trying to induce some tolerance to raise your threshold before you start reacting. We don't get rid of their allergy, because at the end, if they stopped eating that food altogether, they'd go back to square one. Whereas with a ladder, it's they are outgrowing their allergy, and then eventually they can choose to eat that food one day and not the next. Talk about it a little bit with the trying to induce the tolerance with the food allergy, and that if they can only manage a few crumbs, keep that in, and hopefully that means that the body will start getting used to it and you can build it up a little bit. But really what the ladders are doing is trying to find the level that that person can tolerate, and over time then they move on to the next step. So they're slightly different concepts. Vicky? Yeah. Hello, Donna. Okay.
And there's nothing to eat in this house.
Nothing to eat in this house, people. Have you had some ham? Mommy's nice ham. Okay.
I want my egg.
An egg, a boiled egg.
No, a fried egg.
Fried egg. Right. Well, let Mummy do a few more questions, and then I'll have a look. Unless Mummy might do it.
And that.
Okay.
Maybe say hi to Daddy.
You can say hi, Sally, and Beth. I'm going to have to go soon to make fried egg, people, at 25 to 9. Always come home from their daddy's hungry. Right. Hope that helps, Heidi. Did you? Okay. Well, here it was Wagamama's. So, we were advised to introduce nuts that were negative on skin prick test, but given no information on how to do this. How should we do it? So, in terms of do I introduce foods at home, if that person has never had any allergic reactions and the skin prick tests are now negative, then yes, I do. And for families where we want to just do it a bit slowly because there are other allergies and people get a little bit anxious, I basically would say if you can get a nut butter, that's quite useful, or you could grind the nut down into a paste. And then I normally start with like the tip of a teaspoon amount, usually in the morning, so that if there's any reactions, you can manage them and you've got the day. Next day, 1/4 of a teaspoon, 1/2 a teaspoon, 3/4. And for a younger child, you're aiming for a heaped teaspoon. Older children, it might be several nuts that you're aiming for, but start slowly and build up, so that the hope would be if they're going to react, at the smaller amounts, they'd be less likely to have a significant reaction, but we couldn't promise that. The other ways you could do it, if you were using things like nut milk, that could be quite good. Recently been learning that there's all sorts. I knew there was almond milk. I've seen there's now cashew milk, and what other milk did I see the other day? I think there was another nut milk. So you could, again, just start small. So you could start with a few mils and just gradually build it over time. There's no right or wrong. It's just thought that if you just do small and increasing amounts, hopefully if they're going to react, it would be less of a reaction. I hope that helps. I know that once peanuts have been introduced, it's important to keep them in the diet with 2 teaspoons a week. Is this the same for all the other nuts and other allergens in general? And if the answer is yes, is there an age after which it matters less? And does the answer vary if the person already has an allergy to something else? Good question. So the evidence is around peanuts and egg about regular consumption and early consumption. And for peanuts, it was actually a heaped teaspoon of peanut butter 3 times a week, every week until the age of 5. And in doing that, who were children who were high risk, who were children with eczema or an egg allergy, then it reduced their risk of allergy from 35% to 10%. So not nothing. So allergies can sometimes frustratingly still develop even when you're eating the food regularly. There is an element of that's a trial setting. They got rung all the time, giving them ways to keep it in. This is life. Life becomes very hard, but aiming for a couple of times a week, certainly every few weeks with peanut, because it definitely is the one thing where I see that when they become fussy at 2 and they stop eating it, they then become allergic. Tips, if they don't like it, you can buy peanut flour. You could mix it in a yogurt, mix it in food, Bamba sticks, Reese's Pieces, whatever way you can, try and keep it in the diet. Same for egg, boiled egg 3 times a week till they're 5. After that, there's no evidence about the regularity. There's also no evidence about needing to introduce tree nuts before the age of 1 or sesame or any other allergens. It's more about the need to have a variety of food. So the more food, the better before 1. That we do know is a good thing. Improves their gut microbiome, helps long-term health, and risks of allergies and eczema reduce. As an allergist, we always sort of have a sense of if you put something in the diet, we ideally want it relatively regular. You're almost better not giving it than giving it really ad hoc. And this particularly is pertinent for those with eczema. This is where really the risk is that when you stop something for someone with eczema, it's that risk of loss of tolerance. And I really have seen it so many times, but particularly where I've seen it around is milk and egg and peanut. And so those ones are the ones of wanting to keep it in. So with the tree nuts, for me, I say roughly every couple of weeks, every month. I know Penny and Lucy talk about maybe if you just have a jar and you grind it up and you keep it by the cereal and you throw it in. But it is really hard if you're a family who don't eat those things, because the reality is at some point allergies fade into the background and life just becomes life. And, you know, my son had a nut allergy. He's outgrown them. Do we eat them regularly? No. And there was a time when we would put people forward for food challenges and say, if they pass this food challenge, you must make sure they eat it regularly every week. And actually, the evidence doesn't say that you actually have to. Once you've outgrown it, there is no evidence to suggest they will go back into it. So we don't know. So basically, egg and peanut till 5. After that, and the other allergens, no, there is no evidence. And they have looked at it. There is no evidence. So my feeling is, you know, every month would be sort of sensible, but there isn't any evidence. Yes, because otherwise it just feels like it's all becoming prescriptive when food should be fun, and we lose that in allergies. Yeah, somebody said it doesn't have to be overwhelming. It doesn't have to be overwhelming. You can just like sprinkle it in and stuff, but it does feel overwhelming when you kind of like, because then people go, well, God, what about prawns? And some of us don't eat prawns. We love prawns, but some don't. Or what about fish? Or, you know, I spoke to a lovely family and they were Sikh and their child had eczema. So we were really saying, you know, that when you have eczema, we know they've got higher risk of egg allergy forming, and hence the advice about early egg introduction. But that, you know, do you give a food where you're never, ever going to be eating it anyway because it's your religion? But might they be accidentally exposed? Might that mean they have an allergy? And that's a really tricky one. But actually, many of the ways that children with eczema are exposed are through the skin barrier. So because foods often get in the dust everywhere, or because you're moisturizing and there's some residue on your hands when you're moisturizing them. So actually, if you've really got no egg in your house, there's very little likelihood that that child will be exposed, so sensitized across the skin. So for that family, it felt like the right thing for them, because it's their religion, and actually their risks are probably very low, to not give that child egg. And the same sorts of questions are coming up with families that are now vegan, of like, you know, I don't want my child to have milk or eggs because that's not, and you have to just weigh up, well, if it's definitely never there, that hopefully will it be okay. I think it's worse to introduce and pull back, but they are very tricky conversations that we don't have the answers to. Have I answered everything? I'm trying to see. I think I've answered everything on that post. Just go through. And then I have to go and apparently make eggs. Sometimes you just do things for an easy life, don't you? My husband's standing more firm and saying no, clearly, but, you know, I'm going to give in and be me. I know there's lots of questions and I will try and have a little look, but my priority has to be finishing my clinic letters before I upset everybody. I've just been trying to catch up again after my chemo and everything. So as a reminder for this week, we have Tuesday, as we just did on Instagram, Jose Costas, who is a pediatric allergist, although I've learned he does also see adult allergists and adult allergies. And he only works privately. He does a lot of work for various charities, including mast cell activation syndrome. He's coming on to talk to us about environmental allergies. So pollens, house dust mite, pets, molds, what sort of symptoms they trigger, all the treatments that could be involved in improving things, the allergic asthma component side of that. And we'll also be looking at how those allergies can trigger food allergies, something called pollen food syndrome, or some other ones called lipid transfer protein syndrome. That's £10. We give 20% to charity. I will put another link on here later for you to see, or you can find it on our website. And it's live, but also recorded. So if you can't make it, then you get the recording. And you can also choose to buy any other previous talks. Or don't forget, we have our membership. There's never any buy-in. Lots of people reach out and ask whether it's relevant for their situation. We do have more of a child focus in the membership. It is on my radar, and I'm looking for some experts, speakers like my dietitians and psychologists. Just need a dermatologist, and then hopefully we'll have an adult one that we get up and running in the coming months. But I also need to make sure I can give you everything. But we've got adults in the membership too. You just have to be aware that most of the people in there ask child questions, but there's nothing to stop you asking adult questions. And you get a one-to-one to me. So if you are really struggling, we have got some spaces for one-to-one this week, and then I'll be putting much more on for next week. And it's $34.99. And some people come for the month. Some people have come. We've figured out it's not allergy. I've sorted that out, and they've left. And I'm totally fine with that. Other people stay while they're weaning, while they're finding their way through some difficult processes, just to learn some more skills, and then they leave. So up to you. But you get all the expert talks, past and present, for free. So do think about those if you need us, or have a look at our courses. Otherwise, I will continue to pop in and out as I can to answer your questions. There are lots of guides that we've created where you can find some resources, and we will be back live next month for our Q&A, and Emma will put a post up for you so you can start putting your questions up there for me. So have a good evening, everybody. I'm off to cook eggs and do clinic letters. Good luck with all your challenges. If you are ever desperate and struggling, just reach out and drop us an email at support@drhelenallergy.co.uk. Bye, everyone.